Thank you, everybody. That was a fantastic first session. Thank you for the really informative talks, getting us kicking us off on this two-day discussion on where are we in terms of our children in our country and where do we need to go. And a lot was about looking at data and how do we use the data to actually move forward. The next session is going to be different. It's different in terms of the topic, and it's also different in terms of the format, because we're going to do a panel discussion, and I really do need everybody in the audience to be wide awake and take part in this panel discussion with us. So we've got four panelists. We're going to talk about care coordination. So if you say, oh gosh, I don't even know what that is, then this was definitely an important session for you to join, because you'll see how very practical this session is going to be. So our panelists, I will introduce them to you. But before I do that, I just want to actually introduce my co-chair, Ntodeni Ravuluvulu. Ntodeni, do you also want to put on your video for us? Yes. Thank you. So that you can see Ntodeni there. So Ntodeni is sitting on two chairs in this session because she's both my co-chair and she is also on the panel, and she'll explain to you why, because she's actually representing a provincial initiative in this regard. Yeah. So coming back to the topic. So the topic is care coordination. We're going to start with Dr. Annelet Kruger. She is the Tshwane DCST family physician and also from University of Pretoria. And she will be explaining to us the what and the why of care coordination. What on earth are we talking about, and why is it important? Our second panelist is Ms. Jeanette Hunter. She is the DDG of Primary Healthcare Services at National Department of Health. And she will be talking to us about Ideal Clinic and how, do we need to reinvent the wheel, or do we actually have components of care coordination already in place? Our third panelist is going to be about integrated one-stop postnatal care. Can this be done in our setting? By Dr. Nthabiseng Serudu-Nageng. She's from University of Pretoria and will be talking about an initiative in Tshwane District. And the fourth panelist is Ntodeni, and she will be, as I alluded to already, she will be talking about tracing of children living with HIV, the Limpopo examples on this. So each panelist will get an 8-minute introduction slot, okay, and they've all prepared some slides for us, but then we are going to have a panel discussion, so you can start thinking about questions as we go along. We'll pose them to our panelists, and again, it's really about getting a discussion going. So our first speaker is Annelet. Annelet, are you ready with your slides for us?
Yes. Let me just see if I can share.
Yes, and while the panelists are speaking, yeah, thank you. Thank you for putting on your camera as well, because to have a panel discussion, we do need to work on the human factor a bit here. So we do need to see people.
Definitely. Can you see me and can you see my slides?
Yes, both. Thank you very much.
All right, I'm going to just see if I can put it on presenter view on my side. You still see the full screen?
It's good on our side.
Okay, great. Yes, so this is for some people a bit of a fluffy, abstract topic. So I'm going to try and give you some of the overviews, and then hopefully we can also, apart from the examples that my co-chairs will also give, we can have a discussion just to show that this is something that actually works, but it is intentional. So I'm very briefly going to talk about what care coordination is, sharing some frameworks and theories around care coordination, why it's important, very briefly, and then also talk about why it fails and why it's important. So let's start. So care coordination, essentially, when we talk about it, it's not, we're not talking about a single task or a single referral. We're essentially talking about coordinating care. It's the work of making sure that care is connected across providers, across settings, across times, and it's deliberate to make sure that every single patient, and in this case, children, receive the right care, but also at the right time, at the right price, and with the right information. So care coordination recognizes that the patients move through multiple points in the healthcare system, from home to clinics to hospitals, back to their homes, to pharmacies, rehabilitation schools, community services. And if information does not follow them, or if the teams are not aligned, and if no one takes responsibility for all these transitions, then the system becomes fragmented. And that's exactly where we end up with delays in care, with duplications, with misdiagnosis, and with preventable harm. So the purpose of care coordination is to move away from these episodic encounters towards a coordinated, person-centered experience. So it's essentially about turning series of isolated touch points into a continuous and coherent patient journey. So when we talk about care coordination, there are some interchangeable concepts that I just want to outline. So the first one, and the very important one, is continuity of care. And I'll come back to that again, but it's basically talking about care over time. And then the next one is integration of care, and you'll hear some examples of integration of care, but this is how different programs and services and levels of care work together as one system. So, for instance, with child health, we need to link our HIV and maternal and child health services and rehabilitation services and school health and community-based care together. And then we also have person-centered care and people-centered care. So person-centered care recognizes that the patient is not just a string of diagnoses and encounters, but it's actually a person that we need to address biopsychosocially. And then people-centered care is to recognize that this patient is part of a family and part of a community with their own unique challenges and opportunities. So in terms of continuity of care, the WHO has a handbook on integration of care, and it outlines 4 domains of continuity of care. So relational continuity is about relationships, and Ute spoke about the human factor. And this is very important. It's not just the relationship between the patient and the family and the healthcare workers, but also between different healthcare workers. Then we have the longitudinal continuity, and that's the care over time. Management continuity is to have shared and coherent plans for the patients. And I think this is often where we have challenges, that we're all working together, and maybe we have a shared plan with our direct immediate team, but when the patient moves to a different team, a different setting, the plans are not coordinated and integrated. And then the informational continuity is very important. It needs we need complete information for the patient at every encounter. And this is very difficult to achieve without digital tools and structured plans. So I'm not going to dwell on that. I'm sure that is going to come out in the discussion. So why is care coordination important? And I think we all know this. Intuitively, we know it's important to make sure that care continues from one setting to the next, or from one team to the next team. And if it doesn't happen, we have all these challenges. But there's multiple studies, we're not going to go into that shows that if we integrate antenatal, intrapartum, and postnatal care, for instance, it leads to better outcomes in terms of neonatal mortality, improved follow-up for our babies with low birth weights, and better survival. If we integrate maternal and child health care in terms of HIV, then it reduces the missed opportunities for testing and viral load follow-up. And there's also research in terms of mortality reduction. There's big cohort studies done in Norway that actually shows that you have a 25% reduction in mortality if you have continuity of care with the same provider, 30% reduction in acute hospitalization, at reduced system use, ED visits, unplanned admissions, and then very importantly, the patients also have a better experience of care. They have higher trust in us as a healthcare system, so they don't delay in seeking care. So it improves the outcomes, the safety, the equity, and the efficiency, and it's usually happening on a continuum. We have, on the one side, fragmented care when things really go wrong, and then coordinated care if we get everything right. So I'm just going to briefly talk about the relational coordination theory that actually says, this is very useful to look at it from this perspective. It says that effective coordination depends on high quality relationships across roles. So teams need to have shared goals, shared knowledge of one another's work, mutual respect, and this type of relationship supports the kind of communication that allows teams to function under pressure, to ensure that they have timely and accurate communication, problem solving. And without these relational foundations, even when we have good systems, they fail. So this is the human side of care coordination. And then what I want to touch on here very briefly, and I'm hoping this will come out in discussions, is the case manager or the care coordinator. We in South Africa do not have in our public healthcare system dedicated healthcare workers that's tasked with the role of coordinating care. And we know when we have someone, because of the pressures and the staff shortages and the complexity of our healthcare system, the care coordination, although we all understand that it's important, it often falls through. So if we had dedicated case coordinators, it would help a lot. Then we have care coordination as a multi-team function. So I already said, we know that it's not just one team and coordinating care across one team, but we have multiple teams, and they need certain mechanisms, certain conditions that optimize care coordination, and then care needs to be delivered by interdependent teams. So very briefly, for the mechanisms we need for optimal care coordination is dedicated pathways, understanding of workflows and roles and responsibilities. We need to have communication processes and shared tools. The condition that helps these teams to function is accountability, predictability, and a shared understanding. And then also the boundaries of each team should span across different settings, different levels. And I already said we need shared goals, and very important is mutual respect. So care coordination fails when the information doesn't flow, when the roles are not clear, when we have vertical programs, and although we know that we have a lot of policies and frameworks speaking to integrated care, the feedback from the frontline healthcare workers is that they're unclear about their roles when it comes to integrated coordinated care. It fails when transitions are weak, so weak handovers, weak referrals, weak referral letters, when our team relationships are weak, and when there's a lack of accountability. So we need to strengthen care coordination. I'm not going to go into this in details, but the reason why it's so important is that we all know the high burden of conditions that require continuous multi-team care. We have our maternal and neonatal issues. We've already heard the stillbirth and neonatal deaths, HIV, disabilities. So we know that gaps in care coordination is often lead to some of the adverse outcomes. We see this from the audits that we do, and it's made worse by all the vertical programs. But already we have a lot of policies that support integrated care. So these are just some of our policies that we all know about. All of them speak to integrated care. It's not the what, it's the how that is a challenge that we will be discussing today. So we know what we need to do. Care coordination is not an option. It's actually the infrastructure that makes care safe and effective and people-centered. All right. And that's the end of my very brief introduction. Thank you.
Thank you very much. Thanks, Annelet. Okay, so next to go, as already introduced, is Ms. Jeanette Hunter from the National Department of Health, talking to us about ideal clinics. Jeanette, are
Someone's got
you?
to switch my camera on, please. Good afternoon, Uta, and good afternoon to everyone.
Yes, good afternoon. Sorry, your ask was? Yeah.
The host has to switch my camera on.
Okay, so you are on
Thank you.
camera now. Will you please share your slides?
Yes, I will share my slides, and I think as soon as
Yeah,
my slides are up, okay, that's
looks
great.
good. Thank you.
So I'm talking about the ideal clinic and care coordination, and I do believe that Annelet's presentation is going to make it easy for me to stick to time, because I'll keep referring to what she's already said. And I chose today to talk about this topic using Rudyard Kipling's 6 Honest Serving Men. So I'm going to talk about who we are, what we stand for, why we do what we do. Again, what are we doing, how we are doing it. Because as Annelet has said, the very important, when you talk about the devil is in the details, it's always the how. We always know what to do. And who, even though we sometimes fail, as she said, to do proper roles clarification, but we do get stuck with the how, and then, of course, where we are doing it, and the time frame. So this is who we are. If you look at this depiction, the ideal clinic is in the center. It's the dark blue ellipse right in the center. And it's a primary healthcare facility that provides quality services and comprehensive person-centered care. And of course, for it to be, it has to school health services, it has to clinical specialists, it has to have a healthcare outreach team with health workers working from it, has to cooperate with NGO services, have health campaigns, work together with environmental health services, other contracted service providers, and must provide social and psychological services as well. Be the functioning health system, and I'm not going to go through the outside secondary and tertiary services that's presented NG. This is just a different depiction of what I've just said now, starting with the community-based services on the left, moving to the clinics, moving to the fact that we need diagnostic and paraclinical services, we need good medicine supplies, and then, of course, the emergency medical services that came up as an issue in Jaco's presentation as well. Then this chain has to be supported by a good referral system and the implementation enablers, which is our administrative processes. And there's got to be capacity building. When we talk about the framework for care coordination, even when you've documented, as Annelet said, the framework as a policy, there's got to be training and training and training, so everyone understands their role and understands how they need to work together. And of course, communication, collaboration, and that's the only way we'll arrive at universal health coverage. So why are we doing this? So we have a country context in terms of a burden of disease that we need to act on, that we chose to come and work in as health workers. And I think our presentations this afternoon follow on so well on the presentations of this morning, because many of those presentations were communicating our burden of disease in terms of the health of women and children. And so within the country context, we have, if I start
Sorry, Jeanette, to interrupt you. There's a bit of a
And
break in the line, so maybe you want to just actually switch off your videos. Sorry for interrupting you.
we have the patient and community care. Let me to off because I'm on full screen. I can't see
Ah,
it.
okay. Let's see whether we can do that.
So please, is sound okay? Now, okay?
It comes and goes a bit. Now we can hear you. Dave, can you put off the video?
Okay, wait, I actually got to it. It's off.
Okay, we've lost your presentation now.
Am I back?
Yes, you're back.
Okay.
Thank
I
you.
actually
Please.
lost connectivity. And do I sound okay?
You sound better. Thank you.
Okay. So where I was with the country context, I've just spoken, I hope you have heard about the block. I'm starting on the left of this diagram. I spoke about the block that says patient and community characteristics, and that's our demographics and our epidemiology, social determinants of health. So we have that environment that as health workers we want to act on. And then that's complemented by the health facility characteristics, because the health facility characteristics will determine whether we can attract good health workers to come and work in our facilities, and whether the people of South Africa, our communities, want to come and use our services. And putting those two together, you arrive at your patient's experience of care in terms of what access they have. Do they get the medicines that they need when they need it? How clean are our facilities, and do we keep people free from infections, or do we make them sick when they have to use our facilities? And then, of course, the patient's experience of care is enhanced by the values and attitudes of our staff. And the most important, everyone's always complaining about the waiting time. And then when we have those elements working well, we'll arrive at better health outcomes and patient satisfaction, and also with people with confidence in the health system. So what are we doing? We are looking at the infrastructure of our facilities, the physical environment, physical condition of the facilities and equipment, legislation, policies, strategies, and processes that Annelet referred to, and then, of course, the quality of the clinical services. And this is just a picture that shows through our infrastructure program of the Ideal Clinic program, how we move from really dilapidated service provision areas to proper structures for health workers to work in and for community members to be serviced in. I've also just, but Annelet spoke about this, that we do have the policies and strategies in place. So more particularly the how. Within the clinics, we've reorganized services so that people are seen totally in terms of their comorbidities, that someone with diabetes and who also happens to be HIV positive is consulted in the same consulting room and receive their treatment there as well. And we're doing training with regard to this through our adult primary care training program. We have a full primary healthcare equipment catalog, just as an example, to guide people within the facilities in terms of how to get what they need to be able to provide quality services. And then, of course, we have a huge focus on the availability of essential medicines, and our Central Chronic Medicines Dispensing Program, the CCMDD, you see at the bottom of the slide, plays a big role also in continuity of care. And then that tent that we converted into, well, not converted the tent, but The experience of the people being serviced out of a tent that you saw earlier was Lusikisiki. And we built the state-of-the-art clinic in Lusikisiki. And this is the community, which means we really want equity. We don't just want functioning clinics in urban areas, but in the furthest corners. And we're succeeding really well on that. If I had more time, I could talk about that. So what are the challenges, just in brief? Jaco's presentation was actually very good. Again, if you've listened to him, he's saving me a lot of time, because those are the issues that we really have. So it results in, number one, an incomplete chain of care. All the elements I'm going to talk about. One of his first points was about EMS services that's not as good as where they are. And just to use that as an example, we have to identify where EMS services don't work and look at specifically what is causing them not to work if we're going to change that situation. But just to make a statement that, EMS services needs to be improved. We've learned through the Ideal Clinic. Talking about the general doesn't change anything. We need to become very specific and really zoom into particular areas if you're going to change them. Because we don't have an intelligent patient information system, we don't know how we are doing on a public health level. Small implementations, like Ziad has shown us, come up with very good information. And if the sample size is right, you can make inferences on it. But it is time that South Africa has information about the communities we serve so that we can plan better. We also have our incomplete multidisciplinary care teams in the districts, and we need to improve on that. And I've spoken about the lack of an electronic patient record, and this lack causes interruption of care. It also causes a lack of information for care management and ultimately care improvement. So the way forward, we really need to document our care coordination for integrated person-centered care. And I agree with Annelet as well. There are circumstances where we need to talk about people-centered care.
Oh gosh, we could hear you so nicely, and now you're gone.
Again, to fewer people. But when you want to improve care coordination, we need to set up systems that's going to give every single person a good experience, so that you keep them in the system if they need to stay in the system, so that people really, especially people who suffer from chronic conditions, can stay in the system for care and live good lives. And so and what I'm trying to say is really the papers this morning and Annelet's presentation so far gives us good content to arrive at our care coordination framework, and or tweak what we already have, Uta, because I think that's what you are referring to, that we already have a lot of tools, but we can amend them to speak better to what we want to do. And we do need to do a business case so that we can incrementally obtain the funding that we require for all these areas from Treasury. And I think that will be my last slide. Thank you.
Thank you very much. Very happy your bandwidth brought us to the end of your discussion, because these are so valuable points. Thank you very much. I do need people to start engaging with the chat. So either use the Q&A or the chat, which brings us to the next speaker, Nthabiseng, who's going to talk to us. So now we're moving to more really practical examples. So Nthabiseng will be talking about postnatal care from Tshwane District. Thank you, Ntabi. Can you share your slides with us?
Yes, good afternoon, everyone. Good afternoon, Prof. Thank you for this opportunity. Please allow me to share my slides with you. Okay. Please let me know if you can see my screen.
Not yet. Yeah, coming. Yeah,
Can you
so just go and present a view.
present a view? Sure. Okay.
Yeah, all good to go. Thank you.
Thank you. Thank you. So a mother once said to me, Doctor, you know, I spend so much time rather, moving between rooms rather than spending it with a healthcare worker. And this story is not unique. You know, this is what a lot of mothers face in South Africa. And it's really something sad, and this is what shows us why integrated one-stop postnatal care is so important. I'll be taking you through the next few slides, and I'll be talking to you about integrated one-stop care and whether this can be done in our setting. So, I mean, South Africa has done incredibly well with regards to expanding maternal and child health services. And it's so important because the postnatal period is a high risk window for mothers and babies, including, you know, for vertical HIV transmission. Yet our system is still so fragmented, with mothers, infants navigating multiple visits, multiple waiting rooms, and multiple providers. And we know that fragmentation is not good because it leads to missed opportunities, delays across the HIV prevention cascade, gaps in immunization coverage, reduced continuity of care, and greater caregiver disengagement and fatigue. So this brings me to my next slide, which is Sihamba Kunye. So Sihamba Kunye it basically means side by side and refers to the mother and her baby working together with the healthcare professional. And it's a 2-year funded implementation science project with the aim to provide a structured and integrated postnatal care for the mother after delivery, located at the same service delivery point as care for her infant. So if we map out a baby's, you know, if we map out the first 6 months of a baby, we see that, you know, both baby and mom need to come to our facilities like 11 times. This is really, really a big ask. But with a little bit of care and coordination, we can actually reduce this to only 5 visits. So do we have policies and guidelines to help us provide this clinical integrated care? Yes, we do. We have the what, but the question is, do we have the how? So Sihamba Kunye has come up with these processes and tools that help us answer the how. And the tools that we've provided to the nurses is the roadmap and the integration wheel. We've also done time and motion studies, but with the assistance of a lean consultant, where we timed the various care points within a facility to determine how long it will actually take for us to deliver this integrated care package. And to date, we've done over 7,000 interviews with mothers just to understand what influences their decisions around care and around, you know, care seeking health care. So for us to you know, the steps that we need to answer this is that we need to firstly make sure that the mom and baby come together to child health services. And the evidence that we have is that 93% of our babies are actually brought in by their mothers. We see that from the interviews that we've done, we see that in the first 12 months, 95% of the average is 95% across the 12 months. And the second year, it goes down to 88%, but then the overall percentage is actually 93%. So this is really a gift that's been given to us, because if we know that mom and baby are coming together, we do have that opportunity, to provide integrated care. We have the opportunity to do HIV testing. We have the opportunity to offer PrEP. We can give breastfeeding support. We can do HIV PCR testing, because we can get consent from our mothers. So the next essential step for providing integrated care to the mother-infant pair is making sure that we draw both files for the mother and the baby together, and also making sure that when they leave, we actually give them an appointment. Make sure that we align their appointments so that when they come the next time, they come in and present together, so that we can give them that integrated care package. Step 3 is making sure that the nurses know how to provide this clinical care package. And that is, empowering them by giving them these tools, the roadmap and the integration wheel, which I'll show you in the coming slides, what they look like, and how they've worked for our nurses in the facilities that we're implementing. So actually, the roadmap has taken important elements or aspects from existing guidelines, and it's pulled it into one. So it's a consolidated guideline. But the really great thing about it is that, it's not disease specific. It's organized by visit. So it's really easy for the nurse, when they see the baby and the mother, to know which elements of care to provide to the mother-infant pair when they see them. We also have the integration wheel, a really, really fantastic tool, really, that assists the nurses to know what to give, when to give. This is the backslider, and this helps with them knowing how much to give and what the next visit should be for both the mother and a baby. So the next essential step is making sure that there's actually time. And because now, before, if the nurse was maybe only seeing the mother alone, now we're asking her to see mother and baby together. So we actually need to improve and increase the clinical consultation time for the nurse. And can we do this? Yes, we can actually increase the nurse's available time for consultation by decreasing processes decreasing process waste, and by task shifting, and by also doing nurse workload redistribution in allowing her to be able to have enough time to provide this integrated care package. And we have evidence. So the question that we asked, or that we wanted to answer, is, can this be done in our setting? And the answer is yes, this can be done in our setting, because we've got evidence. We've looked at the service integration at 6 months, and we see that, since implementation, there has been improvement. The 6 months HIV PCR and the measles first dose is being done, and we have an improvement of 41% across all our facilities. So this is really fantastic, and this is actually showing us that integrated postnatal care can be done. So why is it so important? Well, there's improved clinical outcomes with integrated care. It's reduced workload for the facility, increased efficiencies, and there's increased convenience for the mother and reduced cost. So in conclusion, we know that mothers bring their babies to child health services. Integrated care is a strategy that can help us get it right by, breastfeeding mothers using a system lens and a patient-centered approach. And this can really help us to get to zero with regards to vertical transmission. And also it can improve our targets with regards to reaching our SDG goals. Thank you so much for your time. I'll hand over back to Prof. Uta.
Thank you very much, Nthabi, for taking us through this project. We will move. So, the questions will be coming after the next presentation. I've already seen questions on, are we teaching? Can you just unshare so that Ntodeni can just share hers? Yeah, so the last presentation will be a practical discussion also from a Limpopo setting, so one of our rural provinces. and then we'll get into the questions. As I say, there's some questions that have come up is like, are we actually teaching care coordination? What are we including in the counseling of mothers, for instance, if we do have integrated care available? So please, now's the time to pop those questions so that we can go into the panel discussion just now after Ntodeni. We can see Ntodeni, but we're not on, I don't think you're on your first slide. You probably have a title slide. Oh yeah, you're quite okay. Yes, good.
Thank you. Good afternoon, everyone, and Prof. Ute. Thanks for the opportunity to present this project. I'm really the reason why I end up being in a co-facilitator and a panel on the and panelists because the coordination is really close to my heart, because when you are working at the rural area where there is resource limited, when there is a limited resources, a proper coordination is really needed to improve the children outcome. So I'm just going to share an example that was just the example of the project that was done to trace of tracing children living with HIV in Limpopo, which was done towards the end of year 2023-2024. Yes, so why this project? It was like we know globally that children, they are left behind, especially when it comes to viral load suppression and also the HIV outcome. So it was also not different with us. It's just that we were also worse, even though our HIV prevalence was low, but our children outcomes were quite not okay. So in 2023 financial year, we had only 75.9% of children in Limpopo remain in care, and also the suppression rate was very low at 58.4, which was also below the national for children for the national, and also which could compare to adults in Limpopo. The adults, it was around 87.7%. So this showed that the children they are constantly falling behind with the HIV outcomes. So the barriers that we identified were mainly missed opportunities, loss to follow up, caregiver challenges, and also low health and literacy and stigma, and also there were issues of transport issues and also insufficient follow-up system. And if we can clearly see here, this is not only a clinical challenge, a clinical problem. It was also we also thought it was also due to coordination problem. So then our province, they decided to looking at this, they decided to launch a pediatric focused targeted tracing intervention, which was led by the local area managers, which we call them LAMS, to address this pediatric loss to follow up to care, and also this persistent and to viral load suppression. So this strategy of local area managers, it was mainly focusing into it was mainly actually the team that was involved because
Yes, ma'am.
Sorry.
Hello,
Okay.
ma'am.
Sorry, can somebody please just mute?
Okay, thank you. So it was mainly focusing on the weekly line lists, reviews, home visit, clinic outreach, and caregiver support. The LAMS were working with the clinics, with the clinic staff, community healthcare workers, and there were also other stakeholders. They were also coordinating meetings with the hospitals with the hospital that this clinic were into, with the catchment area for these hospitals, and also they were also liaising with other stakeholders like social workers, the police, so that we can have a comprehensive intervention. And we also also had monthly into multidisciplinary meetings between the PhD clinics and also the hospital in the catchment area. And this also they were having performance and case by case review at the district level quarterly, where the LAMs were presenting the performance into the statistics, plus also case by case, and also the same with the province. And this really helps us to achieve the goal, because with the LAMP performing presenting this performance dashboard for the local areas and for their local area, they were presenting the retention, viral load suppression, and also number and the outcome of tracing. And also for those patients which were difficult, action were assigned with a clear responsibility and follow up dates to ensure the closed loop follow up. And also with the provincial governance meetings, they were presenting the same, but with this also help us this oversight actually ensure the consistency across the districts and prevent system level bottleneck from persisting. Because, like, give an example where the case where in one of the areas they were having challenges for outreach because they didn't have cars, and this was also presented in one of the governance meeting, and then they were able to into the local area and managed to get the car. And then also, so the outcomes for the outcome for this project, the coordination strategy contributed to the improvement of the outcome. There was a retention which was improved from 70. If we can look here, there was an improvement from 75.9 to 97.1. Currently at the last quarter, because here we have annual and also the quarter we also have data for quarter 1 and quarter 2 for this year. And then the viral load suppression, even though it has lagged behind, which I think the reason that we have to bring them to care, and after that then to care first. So the suppression rate, but now for the last 2 quarters showed a dramatic improvement. Quarter 1, we can see that it went up to around 80%, and then quarter 2 went up to 26%. We are hoping this will be sustained. And also the faster resolution of complex cases through structural escalation, and also stronger communication across the facility. This has brought a stronger communication across the facilities, and also the program managers, especially even with the hospital. With the hospital now, the hospitals are able to do the outreach at the clinics. We identify the clinics that are having challenges with the children who are suppressed, and then we go there as a team. And this has demonstrated the coordination, tracing, and supported by the formal accountability structures. And I think that's what has brought this into these outcomes and this improvement. So, but there's still challenges there that has remained. Some children remain untraceable due to weak community networks, because we still have children who are, especially those children who are living within the house, in the household where the parents are foreign nationals. So sometimes during the holidays, they move across the border across the borders, and sometimes they miss their appointment. And also the caregiver stigma and disclosure difficulties still affecting the community, because sometimes when we go for outreach, and also if we have like all the children were linked with the community healthcare workers. Some of the parents, they didn't want the community healthcare workers to come to their homes because of they were afraid of the stigma, but most of this was addressed through the education, but we still do have some bit of challenges. And so I think addressing these gaps will require and will really require a coordination processes into a routine practice and not relying only on these champions, because I think it's a model that we can it's a model or a strategy that it can be implemented even not only for HIV and also for other long-term health conditions and cases like malnutrition. So this is I think I've already discussed our key achievements, and this is our key challenges that I've discussed. And then with our discussion points, I would like us to reflect on three questions. How do we ensure that the coordination become a reality, not reactive? Because most of the time we do the interventions because we have a problem. So, but how can we make sure that this is it's a routine, not a reactive? And look at the enablers, whether the system, the relationships, the data, or the policies, into which ones will be the most effective drivers for this coordinated care, and also look at how do we protect the coordination from collapsing when staff changes, funding shifts, or workload increases, and so these are the things. I think these are the questions that I wanted to pose to the panel, so we see how to make sure that the coordination of care is strengthened across the country. Thank you.
Great. Thank you very much. We'll come back to your questions just now. But yeah, so there's wonderful reactions to the success story in the chat. So very well done to Limpopo. The one question is like, what type of sample size are we talking about? So how many children with HIV are living in Limpopo or in the districts that you've now been showing us? I mean, are you looking for hundreds of children, or is it, how manageable is the size?
Actually, it's thousands, because it's the whole province. Initially, it was started as like the way they started by just looking out for all children who were lost to care and those who have missed appointments, and then it was just a step. Was just that because I just give a snapshot. So there were many children who were brought back to care. In one of my districts, I think I just don't remember the cases by head, but I do have the numbers. They were above 1,000. But these local area managers, they are allocated in an area where, like, find that they have clinics. They coordinate services for that local area, and they have around 6 to 8 clinics that they supervise, and then they coordinate care for. So yes, with that, the coordination for this project was not only their responsibility, but it's one of the key responsibilities as a local area managers for supervising the clinics, and also supervising the clinics, and also to look into coordinating programs, these priority programs, and also liaising with the community. So this was just part of their key responsibility areas. That was just it was just enhanced for them to trace these children. But yes,
well, I must say that's absolutely amazing to get over 90%. I do think it shows how important context is, apart from the fact that it shows how important it is to obviously have a system and to actually, prioritize key areas. But I mean, you were talking about the issue about car and transport. So obviously distance and things like that are important in your context. Whereas in other contexts, probably the mobility and the movement of children between different households, etc., may be higher. I mean, we are certainly struggling to retain our children in care, because they are not always there where we think they are, because they've moved to another family member, for instance. But yeah, very well done. I wanted to ask Annelet, you were talking about care coordinators, so case managers.
Yes.
So what do you think about, so are these local area managers that Ntodeni is referring to, are they fulfilling the role of case managers? And what type of models should we be using? What type of people do we need as case managers? Do they need to be medical? What type of cadres? How do we actually organize that so that it's not just on a few priority programs like this?
Yeah, thanks. So I've thought a lot about this, and it's obviously not a straightforward answer. I think in this case, they definitely did the work of case managers, care coordinators, whatever term you want to use. Currently, we do not have people who are dedicated case managers, and I think it would help because care coordination really needs to be understood. But I think one of the things in this what we've just heard also illustrate that it helps for that case manager, that care coordinator, to understand the context, to understand the demographics of the patient, and they understand the community where the patient comes from. So it is very helpful if it is someone from the community where the patient lives. We know patients are mobile, and I think people complain about that a lot, but we should understand that and work around that. Patients have the right to move. We cannot fit them into the box that's suitable for us. So if I had a lot of money and I could appoint case managers, it would not just be for a specific condition. It would be in a specific area or a specific facility that knows the area. It is very helpful if they are healthcare workers. Our community healthcare workers understand tracing and they understand the community, but they don't always have the medical expertise to assist with care coordination when it comes to high levels of care, or when it comes to assisting the patient who is currently seeing the pediatrician, but also needs to see the dietitian to understand that dynamic. So I think they can be part of a team, and again, it shouldn't just be one person. Everyone should be involved, but for me, I think it needs to be a healthcare worker. If we had nurses, I know sometimes social workers do the work of case coordinators, but they also don't have the medical people, the medical background. So for me, someone like a clinical associate who are trained in the curriculum on care coordination, I think is someone, and they are doing that in some instances, they're doing it in private. I recently heard in the clinical associates conference that they were appointed in private and they had presented data on the impact they made in terms of reduction in ED visits and mortality and outcome of disease.
Yeah, which is exactly. So you said if we had a lot of money, but actually shouldn't we be turning around that argument and say, because I mean, couldn't we argue, or shouldn't we argue, that we will be saving money if we don't have patients that get lost, and that we need to go and re-find and re-engage, and then they have hospital admissions in between for anything from asthma to diabetes to HIV to TB, because they've now sort of dropped out of the program, and then they reappear and we start from scratch again. So shouldn't we be turning that argument around?
Yeah, and there's evidence to back that, not necessarily in our setting, but there's definitely evidence to back that they reduce costs. So I would argue that I think it would be great if we could have projects. We do, and we actually have this, but we don't always look at the cost. We just look at the outcomes, which is clear what huge impact it makes, and also the patient's experience of care. Just to have someone that can guide them through the process, and someone that they know, the human factor is so important.
Great, thank you. So Jeanette, I am going to put you a bit on the spot from a National Department of Health point of view. I know but the question is primary healthcare, not primary healthcare, it's hospital actually. So you don't need to feel bad about having to answer that. But there's a question in the Q&A around integrated care at Red Cross Hospital. So we would think that this is a dedicated children's hospital. We should be doing the best here. But the question is around encountering challenges combining care for mom and baby, many times due to budget allocations. How, because now, the child's admitted, what about the mom who now needs ARVs and HIV management, for instance, and other interventions while she's there with her child. So I think for me, this is the example that is stated in as a question here is just, it's sad and very typical for our system. We think we're doing the best because now we have a children's hospital, but then we actually dropping the ball in terms of integration. Your thoughts on that and how we fix that as a system?
Uta, I hope you'll hear me. I've got a terrible storm over my house.
It's okay, we can hear you.
Yeah, just quickly before I move on to the question, I saw the question from Red Cross Children's Hospital to say what Annelet says about the care coordinator is right. We need those skills, but I do think we have to start with community health workers because we have them. And because turning community health workers into care coordinators will do a little bit better than what we are doing now. And then we could really identify the gaps that are there through using community health workers and maybe motivate for higher level workers as the financial circumstances of the health system in South Africa improves, because I believe it will. And so similarly, I saw that the question from the Red Cross was asking, would there be resources for that? So I think their problem is the same as our problem, because you're looking at getting the kids, if they're found by community health workers, found on level 1, get them into specialist hospitals if they need it. And then you want to make sure that caregivers, at home, understand the child's condition. There's resources to educate them. There's resources to support them and maybe do mentoring at home so that there's care at home. There's reminders for follow-up care at the hospital as it's needed. And so there is an awareness amongst us, even though we're working in primary healthcare and we started working with you guys in Tshwane, that we'll have to look at the full chain and what needs to be done in terms of the full chain for the individual patients to be cared for properly and to stay in care and to get better. And I do hope that all of us will receive these presentations, because as you know, we've got work to do in this area. And I think all these presentations will help us to have a tool with which to do training and retraining so that we improve the system of care coordination. Thanks, Uta.
Yes, thank you very much. That is very helpful. And it's so good to hear that this is work in progress and that it's really a topic that's also seen as very important. Ntabi, over to you. I wanted to ask, there's been some questions around how to avoid information overload by, how do we structure tools like the roadmap, etc., to reduce information overload. On the other hand, there was a question around, do we, we're in the postnatal period, are these tools also structured around actually thinking around if the mom now needs to go back to work or school, how do we integrate issues like that into our counseling, is this happening, etc. So thoughts on that? How do we best do this?
So it's, working together with the mothers, finding out, when would be an ideal time for them to come back and working with them rather than telling them when to come back. So if we know we have someone who's going to school, trying to see how we can actually work together to make sure that we do get to have mom and baby coming to our facilities together. And because now, the mothers are so happy that they're receiving all these services on one day, they actually are quite keen on coming because they know now that they do not need to come in several times in the, 11 times in the first 6 months. They now can only come in 5 times. So they will make means and plans to make sure that they are able to attend those visits that we schedule together as clinicians, with the mothers obviously working together. And I think probably there was also another question on are the nurses keen on being rotating or doing other scopes of care. And I think because they do rotate within the healthcare facilities, they are exposed to other streams, and there is a willingness for them to, to provide this integrated care to mother and baby because they've seen the benefits. And the benefits is really not just to the facility and the facility managers, but it is also the nurses, this benefits the nurses, this benefits the mothers. So that is really, really great. And sorry, Prof, could you maybe repeat that the other question that you asked?
The other question was around, how do we get help mothers to be ready to get back into school or work, or, and do we even focus on that? Should we, and how do we integrate that into the postnatal care?
Okay.
So in a sense, it's how do we focus not only on the medical part of what we do in clinics?
I think when we care for a patient, it should be biopsychosocial. We should care for all aspects. And I think in us being able to do that is really, again, I'm going to reiterate and say, in communicating with our patients and finding out what is it that they need from us and how is it that we can support them, so that they can still go back to school, so that they can still go back to work and still be able to come and come for their health services.
Mm-hmm. Yeah, thank you very much. I think, you were talking about the willingness of the nurses. I think what was nice about the Sihamba Kunye approach was that the nurses really found it to be a supportive process. Because I think we risk with all the many guidelines that we have developed over the last few years, and many of them have sort of gone down to primary healthcare level from higher levels of care. The nurses at primary healthcare often feel very overburdened. It's like another thing is being dumped on them. And the question is, how do we make it not impossible for them to not to drown in what they need to do? So we do need to keep it as simple as we can, because they are generalists. On the other hand, we are expecting them to do many things at the same time. So yeah. Sorry, Ntodeni, your questions? Coming back, so we are almost ready to wrap up. I just wanted you to have another bite at your questions, and if you have specific panel members that you wanted to have another bite at some of them. We literally have like 2 minutes, so I'm sorry about that, but any burning questions from your side?
I don't really have a burning question, but I just wanted to know from the panel to say if they think with this model that was into this strategy that was done at Limpopo, the LEM, because these LEMs are actually the professional nurses, and they are also trained in many programs, like they were also trained in HIV programs, also in in this data, how to use the data. And then so, yes, it was I think that's what also worked for us, because then they were trained for, and then also the guidelines, so that when they go to the clinic, they will also do the file audits, so they can also check if the children were switched accordingly. As we know, initially we were using Calitra, then there is Dolutegravir, which is more, and also they were switched. They make sure that they were switched. So there were a lot of things that were done, just that I couldn't present everything. But yeah, having someone who's having a medical background, for us really worked, especially for the clinical supervision also, and also coordinating the training for the clinics that they were picking up, that they had gaps in the guidelines. So I don't know if others, they might take a button from one of my questions.
I think you need to ask specifically, name them.
Especially this other one, the one for the card, because remember one of just that I didn't show the slide for the district. One of our district was actually they had an NGO. So when there were cards, there were cuts. It affected them a little bit, but not so much. But other districts, because of and I think it's because of this model that they already this strategy, because already it was already in place, so they were able to recover very quickly also. So the question that I want to so I don't know if there's any I look at the like at the care as a routine and not as a reactive. I don't know if Jeanette can tell us a little bit more.
Yeah, I think that point is very well made. Jeanette, are you still there, or are you in your storm? So I think the point is well made that I mean, this project in Limpopo was born out of the fact that they had a problem. So it's this reactive response, whereas we should be building it proactively into our health system.
Absolutely. It was born out of a problem, but they did something about the problem. And from all the compliments that this project has received on the chat, you can see that people believe there is a need for it. And as you said, our care coordination framework is work in progress. It's going to build on the ICSM manual, the Integrated Clinical Services manual. And then we will have to do, we will only be able to systematize it through training and training and training. That's it from me, Uta.
Thank you. Yeah, so I think, yeah, because I actually wanted to ask everybody to, all the panel members, to have like a 2-sentence summary. So I think that's yours if you concluded with that's it from your side. So thank you very much. I think the training, and I mean, it's a different way of doing things. We're coming from a legacy of very patriarchal healthcare delivery. How do we move towards a person-centered care model? So obviously that's not going to happen overnight. Annelet, last thought from you?
Yeah, thank you so much for the discussion. So I agree that we need to change the way that we're thinking. We're not wired correctly to think about care coordination. It's everyone's business, but it really helps to have someone leading the process. So I think care coordination is a team effort, and the relationships in the team is important. It can be anyone, but someone needs to take the lead, and then everyone else needs to understand where the team is actually going. Thanks.
Thank you. Nthabiseng, maybe a personal thought from your side. What have you learned in the last year about care coordination?
No, I think it really is not a luxury, Prof. It's the standard that our mothers and babies deserve. And I think if we really coordinate care, we can improve outcomes and we can change lives. I've learned so much, and I think that's what we need to be doing for all our patients, especially for our mothers and babies.
Thank you very much. Ntodeni? Last thought from your side?
Yes, for me, I'll still say coordination is not an add-on. It is the mechanism through which all other intervention can succeed, because I think if we can coordinate our care well, it will also reduce the wasteful resources that we have, because we find that we are doing one thing, many of us repeating the same thing. So I think if we can coordinate our care well, it will also reduce some of the burden that we have. Thank you.
Yeah, thank you very much, and thank you for all the engagements in the chat and the Q&A. I'm sure people have also read it. We've not taken all of the questions here, but this is clearly an important topic. It's important on a human level. It's important on a systems level. So we're very happy to hear about the care coordination framework that National Department of Health is obviously spearheading through Jeanette's unit. And then the other thing that's clearly really important, which we have just touched on, but I mean, the whole digital infrastructure that needs to become in place. At the moment, we're utilizing still patient-held records like the Roto Health Book, which is second best, but we should make it, we should really use our tools that we have in place at the moment, like our Roto Health Book. But we should then also be intentional as a country in terms of how do we build a electronic health record that is actually fit for purpose. That's not an M&E tool. It is actually a patient care tool from which we then can also pull our M&E statistics, etc. But really, every discussion we are in, all of these types of discussions, we should always remind ourselves and the whole group that we need to move to a person-centered healthcare delivery system, and yeah, sometimes we forget that in the busyness. But thank you for the really excellent discussions that we had, and thank you for that the panel also brought their thoughts in the initial presentations, and then the really excellent discussions we have had since then. Yeah, so that brings us to the end of this